Thanks, Madam Chairs. First, I'd like to take the time to thank the Scientific Committee for allowing me to present what is, at the moment, probably a topic of great debate, but I would like also to take the opportunity to thank my co-investigators who certainly gave me a hand over the past 12 months or 18 months to put this together. It's fair to say that oxygen at the moment is very topical, and we can see from Glenn's earlier presentation that despite something that we consider routine care in the ICU, the management of oxygen therapy remains a matter of debate. On Thursday, just recently, Thursday, here in this very audience, David Pilcher presented some ANZICS core data that demonstrated that despite more patients being admitted to ICU, less are mechanically ventilated. In fact, with the help of some recent data from Australia and New Zealand, we can quantify this further, with a third of our patients are non-intubated and receiving some form of supplemental oxygen. But despite our education and frequency of use, little is known to help guide bedside clinicians to best practice in terms of the management or in fact the delivery device. This lack of clarity has led to much variation in practice in many critical care settings. Over the past decade, we have seen a development and use of many different oxygen delivery devices and so-called humidified nasal prongs, high-flow nasal prongs or Optiflow. These particular devices have themselves been a matter of debate, but have continued to be considered for use in many ICUs because of their potential ability to deliver much higher flow rates than conventional devices, and therefore deliver a much more controlled FiO2 with better or more optimal humidification, and as we've discussed in the last few talks, with better patient compliance. The efficacy of high-flow nasal prongs in delivering supplemental oxygen has been largely directed towards specific patient groups: those with respiratory failure, cardiac surgical patients, COPD patients, and palliative care patients. So in 2012, our ICU made the decision to change the way oxygen therapy was delivered to all our patients. This was largely driven by the consultant intensivist group, with input from senior nursing staff. It was felt that we lacked a uniform approach to the delivery of oxygen, and the introduction of a unit-wide policy would have some benefits in relation to humidification, and perhaps more importantly, some waste. So the decision to create this policy was not done lightly, and like many changes in practice, we should evaluate it. Prior to the practice change, we developed a plan to examine our standard care in relation to the oxygen therapy, or so-called before period, and after a defined period of time, examine the changes to our practice. The aims were to describe the feasibility of introducing a protocol with high-flow nasal prongs as the primary oxygen delivery device, and determine the safety associated with the changes, identify any implications, assess any cost issues that may arise from changing the device or protocol. To evaluate our change in practice, we performed a prospective before and after study. It was conducted in a 22-bed tertiary ICU, which has approximately 2,100 patient admissions per year. We examined 2 time periods of 4 weeks, which were 6 months apart. We sought and gained ethics approval from the Austin Hospital's Research and Ethics Committee. We examined our routine practice in November 2012. At this time, there was no formal policy or protocol in place to guide the bedside nurses to their device, the humidification, the prescription in terms of FiO2 and flow, or weaning of oxygen during the ICU stay, or the type of device and prescription prior to discharge to the ward areas. In December 2012, we introduced a post-extubation protocol with high-flow nasal prongs as the primary device. We conducted daily in-service education sessions, as well as individual staff education on a shift-to-shift basis to inform the individual nurses of the practice change. Following the introduction of the policy, we allowed practice to embed for a period of 6 months. In May 2013, we examined once again our care in relation to oxygen therapy. For both time periods, we collected information regarding the types and patients and data relating to feasibility, safety and costs. The ICU oxygen policy was a very basic policy. In fact, it was just considered a post-extubation policy at that time with high-flow nasal prongs. The initial settings we described as being an FiO2 of 0.4 and a flow of 40 litres per minute. We allowed the nurses to alter, in terms of escalation or de-escalation, the prescription in terms of FiO2 and flow, depending on the patient's requirements. They were allowed to change the device if they found that this was required, but we did have discharge parameters mandated and associated with the ward educators' support and the staff comfort levels of the ward staff. In May 2013, we evaluated the change after the 6 months, and the collection of the data included the patient demographics, issues relating to feasibility, issues relating to safety, and issues relating to costs. During the 2 study periods, there were a total of 117 patients admitted to the ICU, 57 in the before period and 60 in the post-intervention period. The 2 groups had similar baseline characteristics in respect of age and gender. There was, however, a statistically significant difference between the groups in relation to the number of patients admitted with liver transplantation and pharmacological overdose. There was no difference in ICU length of stay or hospital length of stay. Of the 117 patients admitted, 86 or 3/4 were mechanically ventilated during their ICU admission, with more patients ventilated in the post-intervention period. The median duration of ventilation, however, was similar for both groups. Of the 86 patients that were mechanically ventilated, 83 proceeded to extubation to a spontaneous breathing device. For those patients extubated in the ICU, there was a significant decrease in the use of high-flow face mask or air entrainer device immediately post-extubation in the post-intervention group. There was also a concomitant increase in the application of high-flow nasal therapy in the same group, which equated to a 14-fold increase in the use of high-flow nasal prongs. What we noticed then was to look at, for those patients who didn't require intubation in the ICU, or for those patients that were extubated and then continued their stay in the ICU on a supplemental oxygen device, that there was a significant reduction in the use of high-flow face masks, simple face masks, simple nasal prongs, but also the ongoing application of high-flow nasal prongs. There was also an increase in the total hours that patients were spending on the high-flow nasal prongs prior to discharge to the ward areas. In terms of safety, there were no significant increases in the degree of intubation in the ICU, re-intubation in the ICU, or there was no increase in readmission rates for those discharged to the wards. There was no significant decrease in the amount or type of non-invasive use, and there was, when we looked at humidifier use in the ICU, we noticed that before we made the change, there was a significant amount of patients being treated in our ICUs with non-regulated humidification systems compared to the post-intervention phase, where almost 88% were treated with a regulated humidification system. We estimated the amount of multiple device use per patient, representing either the escalation or de-escalation of therapy and the changes of devices by the bedside nurses. In the post-intervention group, there was an increase in the number of patients using 2 to 3 oxygen delivery devices throughout the admission period, with a reduction in number of patients using 3 or more devices in the post-intervention phase. This change in device use was associated with a reduction in consumable costs associated with oxygen delivery, with 57 patients using a total of 111 devices in the pre-intervention group and 60 patients using 76 devices in the post-intervention group. There was a significant reduction in the median consumable cost per patient stay in favour of the post-intervention period. Our evaluation suggested that a targeted post-extubation protocol has led to some overall change in the use of high-flow nasal prongs in our ICU. We believe this was not at the cost of significant adverse events to patients. We were able to establish a more adequate humidification approach for our patients, and that with the reduction of multiple oxygen device use for each individual patient stay, we've reduced the ongoing consumable costs in this area. We established that the use of high-flow nasal prongs for all ICU patients is safe and feasible. ICU nurses have changed practice in this area quite easily. There is now, though, greater consistency of practice across our ICU, and this has influenced the practice across the wider hospital at the Austin. Thank you, and I'll take any questions.